Welcome to our first presentation and our first discussion for this semester. We're going to take a look at an overview of the DSM-5 and the DSM-5-TR. That's going to include some of the history as well as the changes that have taken place from the DSM-4 to the DSM-5, just so that you know a little bit of the transitions that have happened in the last 10 years or so in this manual. So, a very short history of the DSM. DSM was actually not created until 1952, so it is not even 100 years old yet. The first version of the DSM had 106 disorders across a couple of different major categories and really reflected a psychodynamic perspective on the etiology or the origins of the different diagnoses. We had our first revision in 1968 with the DSM-2. This expanded to 182 disorders, but had a similar framework from the DSM-1. And in these two versions, the 1 and 2, there was not a lot of specification of specific symptoms of a lot of these different disorders. They were distinguished at broader levels, looking at issues such as neurosis, psychosis, and personality disturbance. The DSM-3 in 1980 and the DSM-3 revision in 87 focus on a standardization of the diagnostic categories by linking them to specific criteria or symptom clusters. So this is where we first started to see those lists of, to be diagnosed with this disorder, you have to have X, Y, and Z happening within this time frame. The third version had 265 diagnoses, and the revision added a couple more to get to 292. We had the DSM-4 in 1994. That is going to be the version that most of your supervisors probably learned under, either the 4 or the 4TR, which came out in 2000. This had 297 disorders. The DSM-4-TR has some relatively minor changes from the 3. You see that there's not a whole lot of additional categories or disorders. About 5 more were added. There was not a huge amount of change between the 3 and the 4. And then we had the DSM-5, which was representing the first major revision in 30 years. Revisions of both the DSM-5 and the ICD, currently in version 11, is looking to try to have a little bit more consistency between these two. So you'll notice that the physical health medical part of the world, as well as the most of the other countries in the world, don't use the DSM. They use the ICD, that is the International Classification of Diseases. Most places in the United States, as well as the codes that you're going to see in the DSM-5-TR, are all still working with the ICD-10. So that is a good note to make. The DSM-5-TR was published in 2022. It removed the DSM codes and only provided the only provides the ICD codes. The version that switched from the DSM-4 to the DSM-5, that major revision that we're looking at, was really a commitment from the APA and WHO to try to update this and to make it more of a living document. And they did this with a lot of work groups and conferences and field trials, so there's lots of opportunity for feedback. So I do remember actually when this process was taking place, and they would actually have websites and opportunities for anyone to come in and provide feedback on what should or should not be a part of a specific diagnosis, or if diagnoses need to be moved or shifted. So I do remember opportunities for a lot of feedback from even just the general public or professionals in the general public, as well as those specific work groups that were pulling together experts on the different diagnoses to try to improve and streamline some of these diagnoses. There's now also both print and electronic versions. There's also an app where you can work through the app to try to get to the right diagnosis. I actually haven't used the app, but I've heard some people say it's actually pretty accurate. The DSM-5 did shift some of the structures from the DSM-4. So, one of the things that was a huge part of the DSM-4 was what was called axes. So, there were 5 different axes, and each of these axes had a different area of focus. So, the first axis was where you would see all of our general mental health diagnoses. That would be things like your PTSD, your depression, your anxiety. Any of those kinds of kind of general diagnoses would be on the first axis. The second axis had only 2 different categories. It had intellectual disabilities and it had personality disorders. So only those 2 areas would be put on the second axis. Axis 3 was where any medical issue would be listed. So if there was cancer or if a person had plantar fasciitis or whatever it was, that would all be listed on 3. The fourth axis was kind of our area for any kind of socioeconomic issue. So if there was divorce or homelessness or some other main issue that was the focus of treatment, that would go onto the fourth code on the fourth axis. The fifth one was something called a GAF score, or a Global Assessment of Functioning. And this was a number from 1 to 100, sorry, 0 to 100, that would tell us kind of how well that individual is functioning and what level of treatment they needed. So if you were in maybe the 70 to 85 area, you might just need some outpatient once a week therapy. If you were in like 20 or 30 range, you would be probably a risk of harm to yourself or others and probably be hospitalized. So that code number would tell us where we needed to be. There's also a version for children called the CAFAS, CAFAS, and that is still sometimes used. I know that there's now just now starting to be a shift to get rid of that in some areas. So, sorry, didn't mean to go back. So those were the different axes. Now we don't have any of those. It's just your one diagnosis. The rest of the structure for the DSM is that there are 3 main sections and an appendix. Section 1 is just going to be kind of your introduction. Section 2 is where you're going to spend most of your time. That is going to be all of the criteria and codes for most of the diagnoses. Section 3 is going to be looking at some of the emerging measures and models. For example, you're going to see an alternate model for personality disorders, which has not yet been adopted but has been under consideration. You're also going to see some of those cultural and assessment layers in there. And then there's also an appendix that's going to highlight some of those changes, give you some terms, all of that part. A little bit more of that history. The final draft of the DSM-5 was approved in 2012, released in 13. Most places implemented this in 2014, around 2015, somewhere in those year or two. The coding in 2013 was using the ICD-9 if we were looking at that correlation. We're still really looking at the ICD-10 using the letter and the number. The specific code is going to depend on the specifier. We're going to notice lots and lots of specifiers in these diagnoses. The ICD-11 was released way back in 2015, but the DSM is still aligned with the 10. We haven't yet seen that switch over to the ICD-11. There is a website where you can go and find all of this, as well as scanning through it to get to the right diagnoses. Another change is that you'll see we got rid of this idea of the not otherwise specified. So you used to be able to kind of apply this not otherwise specified to most of our diagnoses. They've replaced this with 3 different items. You could have an other specified whatever kind of disorder, another unspecified disorder, And we still have those provisional diagnoses. So if you think that you might want to rule something out, a person might have a specific diagnosis, you can have a provisional diagnosis before you really assign that to the person. And we're going to talk about a little bit later in this class is the importance of being really careful with how and what you are diagnosing people with. Because you don't want to give someone a diagnosis that is, first of all, maybe untrue, but second of all, something that might follow them and have some negative long-term effects in their life. We do have lots and lots of specifiers. So when you are picking your appropriate diagnosis, make sure you're also including the specifier that's most fitting for that individual. One of the things that we want to look at is the actual definition of what is a mental disorder. So, a mental disorder is a syndrome characterized by a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior that results in a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. And we do note that there has to be typically either a significant level of distress or some kind of impact on functioning, perhaps with social or occupational activities, for us to give diagnoses for the overwhelming majority of disorders. The diagnosis of a mental disorder should have some kind of clinical utility. So it should be something that we are determining to help us figure out the prognosis as well as the treatment plan. So typically, if we find the right diagnosis, we'll have some idea of how to work with treatment for that individual and what we should write into our goals and objectives. If it is not going to be helpful for the prognosis and treatment plans, we might not want to give that person that specific diagnosis. Also, the diagnosis of a mental disorder is not equivalent to the need for treatment. So there will be times when you have someone who actually does have a diagnosis, but for some reason it's not impacting them to the point where they have to be in treatment. Until our etiological and pathophysiological mechanisms are able to identify and validate specific disorders, the most important standard for the disorder criteria will be that clinical utility. So we have to have a good reason why we need to have that diagnosis. It is important to recognize that the reason behind most mental disorders is not known. So for the most part, we don't know why these different things happen. Until we can really determine those factors, it's going to be difficult to fully validate the specific disorders. So a lot of the discussion in moving into the DSM-5 and trying to make it more of that living document was based on the idea that our science was going to progress to the point where we could maybe do a blood test for specific mental health disorders. So maybe we can do a blood test for depression or anxiety or whatever it might be. Unfortunately, that has not really happened. So for the most part, we still don't know why all of these different things happen. Because we don't have those clear biological markers, it has not been possible to completely separate normal and pathological symptom expressions within our criteria. That is why we have that general criteria for most things that says the disturbance causes clinically significant distress or impairment. And that's where sometimes we have discussions of things like many people have symptoms of anxiety. That does not necessarily correlate into a diagnosis of an anxiety disorder. So you might have an individual, or you might yourself, occasionally have some anxiety. But if you don't match all of those anxiety criteria in the DSM, you're not going to be diagnosed with a disorder. So it's very important to recognize that lots of us have lots of minor issues in these areas. Maybe we have days when we're feeling kind of depressed, but it's not impacting our day-to-day life. It's not causing that clinically significant stress or impairment. So we're not going to be diagnosed with that major depression disorder or something else in the depression category if that piece is not there, if it's just occasional symptoms of. So we need to really be careful to distinguish between normal human symptoms or expressions of different things and things that are going to cause that significant distress or impairment. How do we make a diagnosis? That's often a question that we have. We're going to have a couple of different things factoring into it. There's going to be that clinical interview when you're going to talk to your client and really learn about their symptoms and what's going on with their life. We're going to use the text descriptions and the criteria from the DSM-5 TR. And we're going to have to use our judgment to say whether or not that really fits best for that individual. You're going to see a lot of different diagnostic groupings within the DSM-5 TR. We're going to see that these are more or less organized into a lifespan timeline. So things that happen earlier in life are going to be first in the book, and some of those neurodevelopmental disorders. And eventually we're going to move into things that happen later in life, pretty quickly, actually. Many of our diagnoses can happen at any point in time in a person's life. So here's the list from the first half of our DSM-5 TR. And here is our second half. So each week what we're going to do is we're going to look at a couple of the categories. We're going to pull out the major disorders that you're most likely to see in treatment, and discuss those. And we're going to have a chance to perhaps offer some examples of how that looks in real life. So as I said, we're looking at that developmental perspective starting in the DSM-5. The full diagnostic manual provides many of the same informational features as the DSM-4, although it is expanded. But new sections have been added, and the addition of the developmental section is a major thread throughout that DSM-5. So that is really where we're looking at the lifespan and when things might take place. The DSM-5 diagnoses are anchored in the perspective that a pathology in youth is equal to a deviation from developmental norms. So there's some kind of delay in accomplishing developmental tasks or not accomplishing it at all. And these diagnoses fall along a continuum or within a spectrum. The development and course section for each disorder reflects that lifespan approach, the age at which typically symptoms will be presented, the detailed symptom presentation specific to each age group, and descriptions of how this changes over lifespan. So some of our diagnoses you're going to see there's maybe a separate list of criteria for, say, children under the age of 6. The trajectory over time of one disorder becoming another at a later point in time. So there are a couple of diagnoses that tend to have a little bit of a shift over time. So a person might shift from one diagnosis early in the lifespan to something that is more permanent for adults. That is a fluidity of diagnoses. You're also going to see risks and prognostic factors. That is going to include the temperament, genetic or physiological factors, descriptions of situations associated with each age group in which the disorder would disrupt normal functioning. The prognosis is that expected long-term outcome, and it might include points of increased risk or course modifiers or possibility of improvement in stability. This also includes the recognition that changes in the environment can moderate level of impairment in children. There are also some associated features that includes a comprehensive information that the DSM-4 to support the diagnosis. So it might be something medical, other behavioral, emotional signs, other common associations, as well as that parent-child association. There's some information on functional consequences. This is going to refer to the consequences of having a disorder at specific ages or stages in development. And comorbidity. So there are many, many, many different comorbidities. You're going to see this in pretty much every section that there are some things that are commonly diagnosed at the same time. So for example, someone may have an anxiety disorder and a substance use disorder, or a diagnosis of PTSD along with a diagnosis of major depression disorder. That would be something that is pretty common I don't know that I've ever had someone in my office with only one diagnosis, um, and something that you're going to want to be exploring with your clients. There are procedures for evaluating the developmental subtypes of those different disorders. So I have quite a few slides. I'm not going to read through all of them, of the major changes between the 4 and the 5. So some of these things over time has become a little bit less important, but it's helpful to have. So I wanted you to at least have the PowerPoint with all this information in it, even if we don't go through every point. So we already talked about that elimination of the multi-axis system and on the 5th axis, that global assessment of functioning. Clinicians wanted a simplified diagnosis-based system, so they got rid of all those different diagnoses and now just have one number or code or one line in which to place everything. We have established 20 diagnostic classes or categories of mental disorders. One of the big shifts that we'll talk a little bit about when we get there was the introduction of a new diagnostic category of neurodevelopmental disorders. And the big thing within this was that it included autism spectrum disorder and ADHD, as well as other disorders reflecting abnormal brain development. The big change was, I think, on the next slide. Oh, okay, not yet. We'll get there. One of the other changes was introducing more of the dimensionality, so severity ratings, so that we can say things like mild, moderate, severe, that kind of thing. It did not restructure personality disorders as it was discussed as potentially changing. Note that Roman numerals have been dropped. So the DSM-5 starts with the 5, a number 5, the way we're used to seeing it. 1 through 4 all used the Roman numerals. So IV for 4. The idea behind this never really took place. The idea was that they could then have a 5.1, 5.2, and that when there were minor changes, they could simply put on the next 5.3, 5.4, whatever it was, instead of needing to have a full text revision. As we can see, because we are now in the DSM-5 TR, that system did not really happen. So nice idea, didn't really happen in real life. Another change was a new category of obsessive compulsive and related disorders that pulled obsessive compulsive disorder out of anxiety disorder and placed it within its own new category. We also have a new category in the DSM-5 of trauma and stressor related disorders. And this, I think, was a great addition. For example, PTSD is not really anxiety, it is related to trauma. Unfortunately, what did not happen is that there was a lot of discussion and a lot of attempts to get complex PTSD as a separate diagnostic category. And that actually does make quite a bit of difference. So someone who has complex PTSD or post-traumatic stress disorder resulting from kind of long-term relationship issues, typically from childhood abuse or interpersonal violence, is going to have a very different kind of treatment than someone who had a very healthy development growing up, and then maybe when they were 25 had a one-time traumatic event like a car accident. So right now, all of that is still lumped under PTSD. But as a clinician, you're going to know that your treatment is going to be very different depending on what kind of trauma took place. There is another new category, substance-related and addictive disorders. Now includes gambling disorder. Other things did not make it in, but gambling is in there. Within that substance-related and addictive disorders category, we eliminated the distinction between substance abuse and dependence disorders. We put them all into one category of substance use disorders. More severity ratings. greater emphasis on that comorbidity, that there are often, usually more than one diagnosis going on at the same time. We shifted from having a term of somatoform disorders to a whole category of somatic symptom and related disorders. And reorganized mood disorders into two separate categories. I'm going to skip to the one on the bottom here. We eliminated bereavement exclusion from major depression. So we do recognize that someone could have a major depressive episode on top of a loss. Some people say that may pathologize bereavement. What we're trying to say is it's possible to have both at the same time. Hypochondriitis is now shifted into either somatic symptom disorder, if there's physical symptoms, or illness anxiety disorder. Couple other shifts over time. And then here is our list of our different diagnostic categories and the specific disorders within it. So what I was going to say, and I apparently didn't have much information in the slides, but we'll get to it a little bit more when we get to this section on neurodevelopmental disorders. But one of the really big shifts was taking autism and Asperger's syndrome and putting it into autism spectrum disorder. So we now have just one diagnosis where we're going to have that mild, moderate, severe, lots of other specifiers could be included. But what we took away was that Asperger's diagnosis. And that did have some pretty big controversy, specifically for people who may have been diagnosed as Asperger's and did not really consider themselves to be part of an autism spectrum. And I think that's all I'm going to say about that until we get to that section of class. So you can see our major categories. Some weeks we will have one or two or up to four, I think, of these. Next list. And I'm not going to read through these because they are all in your book, as well as listed in other places. So I'm just going to scroll through these briefly so that you can see them. You can see lots of different personality disorders. That's an interesting category to work with. Okay, here's a list of things that have been taken out of the DSM, simply so if you hear these phrases, you know what's going on with it. I'm not going to read through all of these either. I'm just going to highlight a couple of them. Again, Asperger's disorder is now part of autism spectrum disorder. That is a big one. Gender identity disorder is now gender dysphoria. That's going to be a really important one that we will talk about when we get there. Couple things that have moved up that have now become a part of the DSM-5 is binge eating disorder, premenstrual dysphoric mood disorder, a mild neurocognitive disorder, caffeine withdrawal. Notice that caffeine is considered one of those substance uses, and factitious disorder by proxy. Factitious disorder used to be called Munchausen. Factitious disorder by proxy was what we are now calling Munchausen by proxy. A couple of things were pretty much shifted in name, but not necessarily a lot of the actual criteria has been shifted. So notice gender identity disorder to gender dysmorphia. That one probably had more change than most. Sleep disorders is now sleep-wake disorders because there is some issues with falling asleep and just being awake as well. Depersonalization disorder has now shifted to include derealization disorder. And let's see what else we have. A lot of these things you're not going to see a whole lot, so I'm not going to spend a ton going over them. but you can kind of read through, just see the shifts and the changes. Again, some of our new diagnoses include, I'm not going to read all these again, somatic symptom disorder. Hoarding is now an actual disorder. Skin picking is a disorder. Restless leg syndrome is actually in there, as well as rapid eye movement sleep behavior disorder. Lots of different controversies have taken place over this shift as well. So one was around the expansion of diagnosable disorders, that we really, the net result of our diagnostic inflation may be to greatly expand the numbers of people labeled as suffering from a mental disorder or a mental illness. So a lot of these mild ones might actually give some pathologicalization of issues that are kind of normal human behavior. There's been some changes in the classification of mental disorders. Some people question whether that's justified or if that might cause more issues. For example, parents of Asperger's children are concerned that their children may not qualify for the new ASD diagnosis, and they may not get treatment because of that. They might be considered too mild when we're looking at that spectrum. There's some controversy over specific changes in diagnostic criteria for particular disorders. The concern here is that we may not have sufficiently spent the time to validate those changes. So there's been particular concerns about substantial changes made in the sets of symptoms used to diagnose, again, autism spectrum, that can have a big effect on kids who are suffering from that. The process of development was also kind of a point of controversy. So even though there were all of the different work groups and sessions and feedback from people in the community, a lot of people said that it was still shrouded in secrecy, and it did not incorporate input from a lot of the leading researchers and scholars in the field. So that they're saying the changes were not clearly documented based on an adequate body of empirical research. And that is actually the end of our discussion for today. So there's a little bit about the background and history of the DSM-5 TR, and we will get into the specific disorders and criteria as we move through this class. Thank you very much. We will see you next time.